All right, let's get back into some case studies. And we're going to look at some arrhythmias using our knowledge that we just gained from the EKG lecture, hopefully, fingers crossed. All right, here's our case. He's a 48-year-old male in an outpatient orthopedic clinic after an ACL reconstruction 3 months ago. He's been cleared by his physician to begin a running program. He's 5'11", weighs 178 pounds. His father died of sudden cardiac arrest at the age of 54. He's a non-smoker. No current signs and symptoms of cardiorespiratory conditions. He'd been an active golfer and weekend runner. He's not currently taking any medications. You take his vitals and find his resting blood pressure to be 138/88 and a heart rate of 72. So hopefully with any case, as you're going through your chart review or your subjective questioning, you're kind of collecting a checklist of potential cardiovascular risk factors. So his age is relatively young, 48. He's less than the 50. He's 5'11" and 178 pounds. That gives him a BMI of 24.8. So it's kind of the top end of healthy, but still healthy. The family history of heart disease is concerning, and his blood pressure, 138/88, would put him into stage 1 hypertension. So for any patient, you should likely go through kind of a standard ACSM pre-participation algorithm, kind of walk through the steps and see if it is safe to begin running from a cardiovascular standpoint. So if we follow this along, this patient had been exercising normally. He was a regular runner. Do they have current signs or symptoms that suggest cardiovascular, metabolic, or renal disease? Well, we did see kind of stage 1 hypertension. So I would say yes, he's got some evidence that he could have underlying cardiovascular disease. Is this person asymptomatic? Yes. This patient doesn't have any symptoms related to a cardiovascular disease, so no medical clearance is necessary to begin moderate exercise. You can even progress to vigorous if there's no change in symptoms and he had medical clearance obtained in the last 12 months. So we kind of take the steps to go through and make sure this is a safe decision. So let's get this guy running. He's probably anxious to get back to moving again. So we're going to put him in the 0G at 75% weight bearing, and you have the patient begin running. After 5 minutes of exercise, you check his vitals. His blood pressure is 156/86. Is this an expected or unexpected finding? Systolic pressure went up. That's good. We started running. He should have an increase in systolic pressure related to that increased sympathetic drive and cardiac output. Diastolic pressure did not change. Is that expected or unexpected? It should be expected for whole body dynamic exercise. The diastolic pressure represents what's happening in the periphery. And this big cardiac output is being offset by a drop in total peripheral resistance. I would expect no change in diastolic pressure. Or if anything, it could go down a little bit, which it did a little. Let's see, his resting heart rate was 72. After 5 minutes of running, his heart rate is 68. His heart rate has gone down with exercise. Is this an expected finding? No, this is not an expected finding. These kind of questions work much better with a room full of people in front of me, but I can imagine you all began to shout violently at the screen. No, this is very bad. Why would heart rate go down? So there's really no physiological and no real pathological condition that would truly lower your heart rate. Almost always, if you see a decrease in heart rate, this is a sign of an arrhythmia. Because we measure heart rate out in the periphery by feeling that pulse of blood go underneath our finger. If somebody is experiencing an arrhythmia, they may not be developing enough of a forceful cardiac output to get a true bolus of blood. So the heart is actually, there's a good chance the heart's even beating faster, but it's just not generating a palpable pulse wave of blood to be detected. So the way that we record heart rate, it is detected as a lower than normal heart rate. So when you have a decreased heart rate, this is a bad finding, and it's typically associated with an arrhythmia. Please remember, You cannot diagnose an arrhythmia by feeling a heart rate. You would need a full EKG to determine if there is an arrhythmia and what type of arrhythmia there is. But it's helpful to know that if heart rate goes down, this is a likely finding associated with an arrhythmia. So if you have a person in front of you who has an abnormal vital response, the first thing to do is look at them, see what their signs and symptoms are, like their physical appearance, and then ask them how they're feeling. When you ask this patient, he says he is feeling a little dizzy. What do you as a clinician do at this point? Hopefully, your gut instinct is saying to stop exercise. They had an abnormal response and they're having a symptom associated with it. What would you want to evaluate at this moment? You know you're likely going to be either articulating to the patient or a physician or another medical provider what happened. What do you want to measure, record, or ask about? I would want to get a recovery BP and heart rate, taking vitals as they recover to see what the response is there. I would get my stethoscope out and listen to heart sounds. If you hear an S3 is sometimes called that ventricular gallop. It can be a sign of ventricular dysfunction, highly associated with heart failure. You hear S3 kind of early and diastole when the heart is filling, when it already is at high volume or pressure. You could listen to, let me ask this. If you hear an S3, what's the next thing you would go? If S3 is highly associated with heart failure, if you hear an S3, I would drop my stethoscope down to the lower lung fields and listen for crackles. Because if this patient is going into some kind of an acute heart failure, I would expect fluid to start backing up in the lungs. Just kind of tying those things together. It's a really quick way to listen and get a ton of information so that when you call the physician, you can articulate what happened. When you were listening to the heart, if you heard an S4, that's called that atrial gallop. It's a sign of a stiff heart or a hypertrophied heart. What other things? You're going to want to ask them how they're feeling, right, as they recover. So that we ask the patient, how they're feeling as they recover. Bad signs would be, continued shortness of breath, diaphoretic, pale, dizzy, chest pain, severe fatigue. These would be very, very bad findings and maybe suggest a medical emergency. You ask if he's felt this way before, and he reports that he has been experiencing more fatigue and dizziness with some shortness of breath, with mild activity, and rarely even at rest. At this point, I would notify the physician. We found an abnormal cardiac response to exercise with symptoms. The patient is reporting that they have been experiencing this with milder activity and even at rest. This patient needs a medical referral. If the symptoms all have subsided, vitals have gone back to normal, they're sitting comfortably, this is not a 911 call, but I would directly call the doctor and report my findings with as much specific information as is possible. So since a reduced heart rate response is a typical finding associated with an arrhythmia, because the arrhythmia is, decreasing the heart's ability to generate that big, huge bolus of blood to give you the palpable heart rate, it is important to remember the 4 things that we should be considered anytime we encounter an arrhythmia. This might be in a hospital setting on a monitor, or in a cardiac rehab center, or in an outpatient center. The first question you should always ask yourself, is this a new finding? If there is no previous diagnosis of arrhythmia or no previous heart issues, this is a much more significant finding. This is a new finding. If, you see an arrhythmia, it's documented they have an arrhythmia, they're being treated for an arrhythmia, it's not really that shocking. And then you just need to know if this is, the next question down in the list, which is this arrhythmia benign or life-threatening? You cannot tell the nature of an arrhythmia without an EKG. So you can really only, get closer to definitively answering this question if you have a monitor. The next question is my patient taking a medication that could be causing this arrhythmia? Our patient's not taking any medication, so the answer is no. But drugs that can cause arrhythmia high amounts of caffeine, alcohol, tobacco, some cold and cough medications can cause arrhythmia, some psychotropic drugs, and actually antiarrhythmic drugs can cause arrhythmias, coincidentally or strangely. The fourth question you ask is, what are the severity of the symptoms associated with the arrhythmia? This patient did have symptoms, but they were very mild. He reports that he experiencing them frequently at home, which is the really concerning part. So the patient follows up with a cardiologist who ordered a 24-hour electronic recording with a Holter monitor and an exercise stress test. So a Holter monitor is a monitor that can be worn or taken home with them that records the patient's heart rhythms. This provides really helpful information with the diagnosis and management of arrhythmias, because if a patient just comes into the office and they hook up the EKG, they might not catch an arrhythmia if it doesn't happen right in that moment. Many arrhythmias can be pretty random. So a 24-hour monitor has a better chance of catching the rhythm disturbance to help in diagnosing it. So someone might be prescribed a Holter monitor if they're having symptoms associated with an arrhythmia like dizziness, syncope, palpitations, shortness of breath at rest or with activity. The monitor will help describe the arrhythmia, and it can sometimes be prescribed once somebody goes on a med to determine if the med is truly managing the rhythm disturbance, or to monitor their pacemaker when they first get it. So here's the patient, a recording of the patient's EKG, and you can see the full 12 lead here. And then they've separated out just lead 2 on the bottom, since that is the lead, that has the greatest deflection, follows the normal pattern of the heart. So if you feel a little overwhelmed by the full, just take a look at this bottom. Do you see anything abnormal in this patient's EKG? Wide, weird, unusual looking QRSs. When you get down here, I see a pair of them next to each other. The results of this test confirm that he's having frequent ectopic ventricular contractions, or PVCs. PVCs are those wide QRS complexes. This is diagnosed because it was seen in multiple leads. It's not artifact. As a reminder, a ventricular ectopic beat is a beat that arises from an irritable focus in the ventricle. And because it doesn't go down those, bundled branches in that clear path, it spreads along the ventricle in an abnormal pathway, which creates a very wide QRS and a kind of rather bizarre looking T wave. Because the ectopic beat arises in the ventricle, there is no P wave for the PVC. So here's a slide that illustrates that phenomenon. Here's kind of the irritated section. That would be the starting point of that depolarization. So the depolarization kind of waved out in multiple directions. It would be a much different path than when the action potential that gets the ventricle comes from the AV node and spreads along the Purkinje fibers. Because the path is different, the EKG recording looks different. So they found these multiple PVCs, and there was distinct EKG findings indicating that they were arising from the right ventricular outflow tract. So from the EKG, they can truly kind of narrow where they think this ectopic foci is coming from. Given this patient's family history and the frequency of symptoms, the cardiologist recommends a cardiac ablation. A cardiac ablation is a minimally invasive procedure where a catheter is threaded through a peripheral vessel. It could be through the femoral vein or internal jugular vein, or sometimes the subclavian vein, and they guide the catheter through the tube into your heart. So this is a video-guided path. The sheath is like a small straw-sized tube that allows kind of all this equipment to move through it in order to be delivered to the heart. So once the catheter has reached the heart, they need to locate the abnormal tissue. So the catheter sends out small electrical impulses, and then the other catheters record the electrical activity to try to find which site of the heart is abnormal. Once you find the abnormal site, the catheter can emit mild radio frequency to destroy cells. Sometimes it uses local heating or freezing to destroy cells. But it permanently destroys a small area that had been irritated, so it stops creating the abnormal beat. The area that gets destroyed is typically somewhere around like 1/5 of an inch, just to give you an idea of, just a small little area stopping that irritated tissue from causing these unexpected beats. The whole procedure takes around 2 to 4 hours. It can last longer if they have to do multiple ablation sites, but it is a relatively simple procedure that can end these ectopic foci in the heart. So the patient tolerated the procedure well and was up walking the halls 5 hours after the procedure. He was kept overnight in the hospital for observation, and he resumed physical therapy for his ACL reconstruction 1 week later. The heart is typically considered healed after about 3 months after the ablation. So some patients will be given some lifting restrictions for like the first week, like no 20-pound or more lifting for the first week, no strenuous activity for just about a week, and then patients largely return to their kind of regular life. So this is a great example of a PT being the one that noticed a cardiac issue and allowed the patient to get quick, effective treatment. It barely, even set aside his ACL reconstruction because it was identified and addressed and treated, and the patient was back on track. All right, let's do another case. So another arrhythmia case. This is going to be a 55-year-old school administrator who developed atrial fibrillation over a 2-year period. The symptoms related to the AFib included fatigue, shortness of breath, and a decreased ability to exercise. The patient was treated with beta blocker and warfarin. So in our little mini farm review, we have not yet talked about beta blockers. So the type of beta blocker a patient is on, they differ from one another. They differ in the selectivity of the beta adrenergic receptor, and some of them may have more or less vasodilation capabilities. But you can always tell that it's a beta blocker because it ends in the OLO, the OLO. Do I have it on the slide anywhere? No, I don't. The OLO is the classic ending, right? All of these guys end in the OLOs. The main goal of the beta blocker is to reduce myocardial work. And the reason you want to reduce myocardial work is you can prevent that increased myocardial oxygen demand, so the blood vessels can better keep up with the heart. So since our beta adrenergic receptors are our fight or flight receptors, by blocking the beta adrenergic receptors, you're going to reduce the normal sympathetic response in the heart. So you can see that the action then reduces heart rate and decreases the strength of the ventricular contraction. The side effects, it's always helpful to think about the side effects of kind of what are some of the other things that the sympathetic nervous system does. Well, it bronchodilates, right? So when you're given a beta blocker, you can get bronchoconstriction. So this drug is sometimes avoided in asthmatics. You can get too much cardiac depression, where they're unable to mount enough of a cardiac response to maintain hemodynamic stability. And then this drug can mask some of the symptoms of hypoglycemia, because a lot of the subjective feedback that patients use to know they're becoming hypoglycemic are related to the sympathetic response to the low blood sugar. So it can be dangerous for patients who have poor control of their blood sugars to be on beta blocker if they rely on their subjective sensation to be their main driver of that response to hypoglycemia. So this is a pretty common drug, so it's important to think about this in relation to exercise. If you are treating someone and they're on a beta blocker, just the fact that they're on it should tell you that you should take vitals, because they're on this drug likely because they have some kind of history with cardiac issues. Because this drug is going to reduce the sympathetic response, it can affect how they respond to exercise. The first one on this list might surprise you in that some patients on beta blockers actually increase their exercise tolerance. If cardiac ischemia was the limiting factor to their exercise tolerance, by keeping the heart rate lower, they sometimes can actually tolerate exercise better. The big one that I think has been kind of pumped into your head at this point is that you expect a blunted heart rate response. So because this drug reduces heart rate, you would expect kind of a sluggish or lack of responsive heart rate. And for that reason, it is an ineffective tool to measure exercise intensity, and you want to rely on an RPE. So just to give you the background, the most common conditions that use beta blockers are coronary artery disease, patients had heart failure, hypertension, and it can be used in hyperthyroidism. Okay, our patients also on warfarin. Warfarin would be on board to try to reduce the chance of a clot. So atrial fibrillation is highly associated with clotting because you don't get the blood kind of moving out of the atria at a regular rate, and the fibrillation kind of creates a little shaking of the blood in the atria, and you can activate clotting factors and induce a clot. The major side effect then would be bleeding, and you'll know how much they're at risk by looking at their INR. So atrial fibrillation, again, is when you have ectopic beats arising from other areas in the atria. And instead of causing just one kind of premature atrial beat, it creates these re-entrant circuits where the wave of depolarization circles back and reactivates that initial spot. In atrial flutter, you would have just one of these re-entrant circuits. In atrial fibrillation, you have many, many of them. So all these little individual sections of the atria are contracting at their own time, independent, and typically extremely rapidly. So when you look at the EKG, there are no noticeable P waves because there's no coordinated contraction of the atria. The only way you're going to deflect the line on your EKG lead is if there's enough cumulative electrical activity to be recorded. There's a lot of electrical activity happening here. It's just totally discordant with each other, and so it doesn't ever kind of accumulate to rise and make a true wave on an EKG. So atrial fibrillation is a form of supraventricular tachycardia. It is a benign finding when the heart rate is less than 100 beats per minute, but it can become problematic when your heart rate is over 100 beats per minute because it can compromise cardiac output. So atrial fibrillation is relatively common. It becomes a big problem when heart rate gets too high because they may not be able to maintain cardiac output, and it has this huge increased risk of clotting. So I included this chart of antiarrhythmias, hopefully to help you with studying. I will not be asking you, the specifics on this exam of the mechanism of action, but let's just go through it as a review together. Since we just reviewed the cardiac cycle, let's look at where these act. So this little aside, you can write on a blank space on the back side of a sheet or add a piece of paper because there isn't space in your notes for this. This is just something I've ended up doing in a couple of years previous, as some students have found it to be helpful. So this is millivolts on the left. So we've got 0, kind of negative 50, and we rest at around negative 90. So here's kind of our resting phase. Then we have this, my line didn't get connected. Let me do that again. So you have this up, and then we kind of jump up in this massive depolarization. You get the plateau, and then back to repolarization. So let's remember what happens at each phase. Phase 0 is from the large sodium influx. Those fast voltage-gated channels pop open and you get this, big depolarization spike. When you get to point 1, we start to see those sodium channels closing, so you get less sodium movement. The potassium starts leaking out. But then at phase 2, this big plateau is from that movement of calcium. These slower gated calcium channels that open that allow the calcium to move out, calcium to move in, the influx of calcium, maintaining that positive depolarization state. As the calcium channels close, we go into phase 3, where the movement of potassium is dominating the repolarization and we get less movement of calcium until we get back to resting membrane potential. So kind of keeping in mind the ionic movements, if we look at the drugs, our class 1 antiarrhythmias interfere with the sodium channel. They interfere with the sodium channel. The sodium is our fast-acting channel. So when you interfere with the sodium channel, that is going to make the ventricle less excitable, because to get the initial spike, you need the sodium channel to open. So class 1 drugs kind of decrease the ventricular excitability because they mess with that sodium channel, which is the reason that you get your initial depolarization spike. If this helps with too much excitability, that's why this is used for VTAC and VFib, because you want to reduce the chance of an action potential. Class 2 are just our beta blockers. So they act more at the level of the receptor than in these individual ion channels. Class 3 are going to affect the potassium efflux. It's going to delay the phase 3 repolarization. So class 3 drugs delay phase 3 repolarization. They effectively make a longer refractory period. So the heart is protected from another action potential longer with the class 3 drugs. And then finally, our class 4 antiarrhythmia are calcium channel blockers. So calcium channels were really important in the SA node, where we had that kind of slow leaking kind of shape, and that is because calcium channels get activated in the SA node. So the class 4 calcium channel blockers really significantly impact the depolarization of both the AV and the SA node because of this larger significant role of calcium channels. It can very much, slow that depolarization, which can decrease conduction rate. And very importantly, can decrease heart rate when it's driven by the SA node. So for that reason, because these are so significant in the SA node firing rate, this class of drugs is largely used when there is supraventricular tachycardia. It's a mini review. It just sort of helps to lay two concepts on top of each other so that when you're studying, you don't feel like you just have to memorize a bunch of drugs, but rather think about them in relation to what you already know, and it can make a lot more sense. So let's go back into our patient. So they tried doing rhythm control with one of the medications on our list, but the patient failed to control their rhythm with drugs. So a pacemaker implantation was ordered. This patient was instructed to discontinue warfarin 2 days before the hospital admission. This is a really common requirement for someone who's undergoing a procedure or a surgery. Warfarin has a really long half-life of about 40 hours. So they discontinue the warfarin to reduce the risk of bleeding, either during or after the procedure. Now, depending on the patient's history, they might kind of switch over to a shorter acting drug, kind of like heparin. So someone who has very high clot risks might be treated with heparin as what's called a bridging anticoagulant during the time of the procedure. Many patients aren't. They just take them off warfarin for the procedure to avoid the risk of bleeding. The reason heparin is kind of beneficial as a bridge anticoagulation, it has a half-life of 60 minutes. So it's a very different timing of that drug related to the bleed risk. This procedure, the implantation of a pacemaker, can be performed in a cardiac cath lab. It's under sedation and general anesthesia. So a pacemaker has an electronic pulse generator that's used to create an action potential. So it creates an electrical voltage difference between two electrodes to artificially cause a depolarization. At the very end of our EKG lecture, we looked at the EKG, and you can see kind of a straight line on the EKG that represents the pacemaker spike, that artificial depolarization caused by the pulse generator. Now, someone can get a temporary pacemaker. This is if someone's experiencing like transient arrhythmias during or right after a myocardial infarction, or right after a heart surgery when they might have really high vagal tone. They might get a temporary, just external pacemaker. Permanent pacemaker is surgically implanted. Most have a lithium-ion battery, so it has a half-life of more than 6 years. So on average, a pacemaker battery is changed about every 10 years. Patients will go in biannually to test the battery and the working order of the unit. So you can see the placement of the pacemaker, where the pulse generator is placed just under the skin, typically in the left intraclavicular pocket. It may be on the right if there's some kind of medical issues on the left, or if they're left-handed, but almost all patients have their pacemaker in the left intraventricular pocket, the infraclavicular pocket below the clavicle. Then the leads, so you can see the leads coming off the pulse generator, are threaded into the heart. And the tips of the electrodes are going to be in direct contact with the interior surface of the heart. They may be pacing the atrium or the ventricle, but you need the tips of these leads to be in direct contact with the either right atrium or right ventricle. They can be screwed into place, they can have hooks, they can be sewn into place, but they need to be in that direct contact. These leads are threaded into the heart, through one of the main veins. So typically they thread this through the subclavian or the internal jugular or the cephalic vein to kind of wind their way into the heart, and then through the heart if they're going into the ventricle. How the pacemaker controls the heart is also variable. A fixed rate is just what it sounds like. It paces the heart regardless of what one's own heart or rhythm is. It has a set pace, and that's what it delivers. That's the fixed rate. A demand or inhibited pacemaker mode has the ability to sense native atrial activity. And if the atria of the patient's heart is appropriately contracting, the pacemaker is inhibited. If there's no atrial activity sensed, then the pacemaker turns on and takes over. So in demand or inhibited mode, the pacemaker turns off when it's not needed. In synchronized mode, the pacemaker paces whenever the conduction system fails to pace, and when the heart is kind of working and creating a beat, it also paces, but it goes in unison with the activity that it senses. So in synchronized mode, the pacemaker does not turn off. It's just going to pace, matching the individual's intrinsic rhythm. So in the demand or inhibited mode, if the intrinsic rhythm is there, the pacemaker just shuts off and it's quiet until it's needed. In synchronized mode, it will send that depolarization, but it will match the rhythm that's being controlled by the patient's nervous system. So if you're looking at an EKG for these, just know that, we talked about seeing that pacemaker spike, that straight line. If, the pace is immediately before the P wave, that kind of shows this atrial pacing, but not all spikes look the same. So it can go, in the negative direction, it can go in the positive direction, it can spike through both. It can be above or below the isoelectric line. It doesn't really matter what it looks like, kind of where it falls in the EKG gives you more information. If you would be looking at the PR interval, it would be the pacing spike to the R at that point. So the patient gets their pacemaker. This image, you can see what it looks like to have the pacemaker pouch just below the skin. And here is a chest x-ray where you can see the pulse generator in the infraclavicular pocket. And you can actually see, just below my green line, the leads going through the vein and down into the heart. And here you can see the bottom of the ventricle and that final lead being placed into the ventricular muscle tissue. This patient's returned to his room and placed on continuous telemetry monitoring. So they want to be tracking this patient's vitals to make sure that everything is normal, that the pacemaker is doing what it's supposed to be doing. Vital signs monitored periodically, and the pacemaker pocket site is inspected for signs of excessive swelling or bleeding. The most common complication after a pacemaker being put in is bleeding or swelling at the pacemaker pocket. A chest x-ray is done and a 12-lead EKG is completed. The chest x-ray is used to verify lead position, and the 12-lead EKG is used to verify pacemaker function. The patient is given activity percussions for 4 to 6 weeks to allow firm lead adhesion. So this is a relatively easy procedure. It works really well. The big thing that they do not want to have happen is something to pull on the leads and dislodge them from that direct contact with the heart. So for that reason, the precautions that are given is they keep the involved upper extremity involved as the side that the pacemaker pocket was generated on, and they have it in a sling for 24 hours. They don't want anything to be tugging on those leads for the first 24 hours. There is no Therax to the involved shoulder for 4 to 6 weeks. And for 4 weeks, you do not raise that shoulder above 90 degrees on the same side that the pacemaker was put. The fear is that when you raise the arm, you'd pull on the leads. Minimal weight bearing on the upper extremity when using ambulatory devices, and no lifting more than 5 pounds for, again, 4 to 6 weeks. So the goal here is to allow adhesion and incision healing. This involvement of the shoulder can be really problematic, and you might see patients in an outpatient setting because if you're not letting someone move their shoulder, especially above 90 for 4 to 6 weeks, there's the possibility they can develop adhesive capsulitis. This is a relatively common kind of negative side effect in our diabetics who are more prone to those connective tissue issues. Now, I gave you kind of the standard precautions. This is completely dependent on the surgeon preference. So you might see deviations from this, but if you kind of keep in mind what the goal is, it should hopefully make sense. For this reason, axillary crutches are really not recommended due to the stress on the incision and kind of venous pressure in the axilla. So even if someone is younger and maybe could use crutches over a walker, it's not recommended because of that pressing kind of into that axillary area. Patient tolerated activity well. They demonstrated independence with their activity limitations. They understood the precautions related to the pacemaker and was discharged home the next day. These are the happy cases. We can do so much to help with rhythm. It's very rewarding. I hope you guys enjoyed the lecture and that you're having a great week. Bye.